Are the feelings of our own expert, Dr. Ranjeet, who joins me now. Dr. Ranjeet, a very powerful missive from France. I expect that's the feeling amongst health service workers here in Britain, is it?
Thanks, George. A pleasure to be back with you on the show again. Are you hearing me okay? I'm not seeing you.
Very well, very well.
Good stuff. Yeah, I think the medical implications people are becoming more and more aware of. The economic and social implications of this are continuing to unfold. That message I just heard you read it is powerful and unquestionably poignant and topical. It made me recall, a few statistics. We know that 850 billion is spent annually by the United States on its military. When a fraction of that, perhaps 30 billion, would be enough to eliminate hunger in the world. We know that there are a very small minority of billionaires who hold between them, in fact, 6 or 7 billionaires who hold between them the same amount of money as half the world's population. These are facts and statistics which are not new. Not long ago in our own National Health Service, I was involved in fighting against the imposition of a junior doctor's contract, which I was very worried and my colleagues were worried about, was leading to a downgrade of pay, downgrade of conditions, making it less attractive and less easy to recruit and retain junior doctors. At the same time, the nurses' bursary was being taken away. Nursing has traditionally been, a profession that's open to intelligent and predominantly working class young women, but also men who can't afford to pay tuition fees for long periods of time to support that noble profession. We know that conditions for nurses were getting so bad. Not long ago, I was working in the capital in St. Mary's Hospital. I knew nurses who couldn't really afford to carry on working, were having to leave the jobs that they loved. We know that there are cases of nurses being on food banks. Has been a topic within elections. So the chronic understaffing and underfunding of our NHS is something that we really need to look at and address. We know that capacity, we've discussed before, has been going lower and lower. And this crisis, like every winter crisis, actually highlights this problem. But this crisis is perhaps bringing it in a really sharpened and acute form before the workers of our country and of the world. Why is it that we have only perhaps 8,000 ITU beds, when even a country like Germany, yes, slightly larger but not incomparable, would have as many as 35,000? A case regarding the junior doctor's contract was when that contract was imposed, we had our whistleblowing protection removed, so that junior doctors who brought to the public attention facts that they thought were making the NHS unsafe in this trajectory of privatization and cuts actually were denied and debarred from training. There's a very famous case of a medic called Chris Day. Maybe worth you trying to get him on the show. Not someone you'd accuse of being left-wing, but someone who he would accuse of very much caring about the care that he delivered. Whilst he was working at a PFI hospital in southeast London, he found that the staffing levels were so low at night that he, as a junior doctor, was looking after 12 patients in ICU by himself. He felt this was unsafe. He raised it repeatedly within the hospital. He raised it during his training ARCP. And when he raised it, he was, while initially praised for being a good and conscientious doctor, subsequently denied his training, denied his number, and denied his career, essentially. So there are real problems that are underlying the delivery or the difficulty in our NHS delivering the kind of care which is needed at this crisis time. That said, I know that my colleagues are struggling to do the absolute best that they can with what they have and the resources they have. And you have to say, if we talked a week ago and felt that very few measures were being taken and made certain demands, it's as if, a higher government source was listening to your show, George, because huge amount of action has been taken, you have to agree, on a daily basis, more and more economic measures being taken. But the NHS itself is short of equipment, is short of staff, and I'm afraid that despite our best efforts, we will struggle if we really are 2 weeks behind the curve and we start to see the scenes that we're witnessing, the horrendous, the tragic, but perhaps in hindsight, avoidable scenes that we're seeing in Lombardy today?
Yes, there are many things arise from what you just said. Most of my demands from last week have now been realized, not them all. And of course, some of them cannot be realized in a week or a month because they are the bitter fruits of 40 years, as I put it, of neoliberal politics. It's not just the Tories, for those auto-laborites who like to date all these problems from 2010. As a matter of fact, they date from 1979, 1980, and it will take longer time to resolve those. And one of them is that we've been living under the illusion that we have a national health service, the pride of the world, an example to the world. People look at, they still say it about the BBC and they still say it about the NHS. But in fact, quietly, silently, more or less silently, large parts of the NHS have been undermined, underfunded, so profoundly, and deliberately so, so that privatization would be seen as the only appropriate cure. And for those who could afford it, and had no ideological quibble about doing it, why don't you go into the private health sector? In fact, the National Health Service has been quietly murdered over 40 years, hasn't it?
I think that's an entirely reasonable and sadly accurate point, George, and there's a number of reasons why that has happened. Of course, I mean, Ernest Bevin first said that in order to create the NHS, he had to stuff the mouths of the consultants with gold, was his famous quote, that he had to preserve private practice, enable certain elements of the private medical system to survive. And while that became very much a minority system for many years, you know, as the Keynesian consensus, if you like, of social welfare has gradually unfolded, the NHS itself has been seen as a ripe fruit for businessmen to pick at. And certainly it's the case, you know, I can't go into the whole policy, but the bringing forth of the internal market so that all of the NHS was divided up into different trusts who barter, who sell services to each other rather than planning. You know, if you're a family and you know what you need and you know what you have, you can plan to procure what you need. This system, which is a socialist idea and is extremely efficient, has been decried by the Tories for a long time. Many of their backbenchers, if you look it up, you can look on Google and you can find that they decry the NHS as a Stalinist system. Oliver Letwin and I think John MacDonald, Oliver Letwin and one of his colleagues came up with a concept under Thatcher to privatise the NHS. They called it Britain's biggest enterprise. You can look that up and see it again on Bob Gill's excellent movie, The Great NHS Heist. And they talked about the ways in which you could gradually pick off what they called peripheral services. So when I was very young, before I was a doctor, long before I was a doctor, the Hillingdon Hospital workers were fighting a strike because the cleaners at Hillingdon Hospital were being privatised. They were actually being sacked and asked to be re-employed by a private company doing the same job but at a substantially reduced wage, without benefits, without holidays, without sick leave. And this, as we've seen now, as a process that has run throughout the NHS. Capita and various other companies have come in. They run the kitchens, they run the cleaning, they run the carpentry, they run initially peripheral services, maintenance. Then, of course, there was the PFI. And increasingly, they've taken even central services. So, first of all, elective surgery, things which you could make some money up, was sold off to private interests to provide. And bit by bit, albeit under the stamp of the NHS, more and more of our healthcare is provided by the private sector. And, of course, that means under the 2011 Health and Social Care Act, actually Matt Hancock, though he's the Secretary of State for Health, does not have responsibility for the day-to-day running of the NHS. You know, Boris, as we pointed out previously, found himself unable to manipulate and change the plans of the NHS. This was before the COVID crisis, when he promised the northern constituencies and his Brexit constituency that there would be some material benefit that accrued to the NHS. And we see this again, and there's been almost deadly silence from Simon Stevens, the chief executive of the NHS, who should be responding to and running this crisis. Italy has commandeered and nationalized essentially its private medicine in the face of this overwhelming emergency in order to help deal with the situation. Britain has taken a cop-out, if you like. It's very keen to preserve private medicine and the privilege of private medicine, and therefore it's offering huge amounts of money, and millions per day, to contract out services.
2.4 million just for the beds alone.
Absolutely.
Let's go back to how things are on the front line. I mean, you're a heart surgeon. My wife will be expecting to go in just a couple of months, 3 months, for delivery. Are the hospitals doing any other work, or are they completely swamped with this? Are you doing much heart surgery? Are the labour wards going to be open in July when my wife goes in?
Thanks, George. I just correct one small point. I'm actually not a cardiac. I'm a vascular surgeon, which is a fine point that not everyone will appreciate. But I'm an arterial surgeon, yeah. And yes, we are performing still emergency surgery. And actually, in a specialty where perhaps 70% of our workload is made up of emergent and urgent cases, so things that can't be put off because they are life and limb saving. We perform operations when people have had strokes, operations when people are bleeding from ruptured aneurysms, operations to save people's legs. These things can't be put off. Anything that can be put off, the elective surgery, the hernia surgery, the varicose vein surgery, things that have real material benefit to patients, but doesn't need to be performed precisely at this moment. We're doing our best to defer that. I've been running telephone clinics this week. I've been trying to contact my patients, go through their results without them having to come into the hospital. Many of my patients are elderly. They have multiple comorbidities, the diabetes, the cardiac disease, obviously the peripheral vascular disease. They've had previous strokes, some of them have impaired renal function. So all of these patients are particularly at risk if they come into contact with patients who have the coronavirus, and therefore we're doing our very best to keep them away from hospital so long as we can manage their conditions in a safe way, at least temporarily. If we can temporize and put off their appointments, that is the best thing. And if patients don't feel that they're in urgent need of attention, they should absolutely do their best to contact the hospital. They might find it hard. They might find the hospital is trying to contact them, as we have been doing, in order to defer care that can be put off. Currently, if you look at what's happening throughout accident emergency departments and intensive care departments, they're doing their very best to expand their capacity with what they have. That means A&Es are being divided up into respiratory areas and non-respiratory areas. China this week published a fantastic document from Zhejiang University, I don't think I'm pronouncing that quite right, but a medical school hospital in the Wuhan area, which summates its experience in dealing with coronavirus. And
fantastic part of that document. They've sent it all around the world, yeah.
They have, and I really highly recommend my colleagues in the medical profession to look at it. The National Institute of Clinical Excellence have published some emergency documentation, but it's very limited. A lot of it is about triaging patients, about assessing their fitness for intensive care. But the latest really modern healthcare system that has done such an excellent job is China. This summates their experience, including their reference and experience with antiviral drugs, because our own local recommendation is still that there aren't antiviral drugs that work. That's not the experience of the Chinese. They have found particularly lopinavir and ritonavir, which are protease inhibitors, to be useful, and also some anti-TNF alpha drugs, which can be inhaled for patients who have this severe respiratory syndrome, the SARS part of the infection, as a nebulized medication that's being produced by China and Cuba in collaboration. And I think, as I just heard on your news, it's for that reason that a large group of Cuban scientists and medical personnel are in fact going to Lombardy to supplement the impressive Chinese aid, which has been in such stark contrast, for example, to the European Union.
I'm amazed, Doctor, at the absolute silence and inaction from both the EU and the US. There's a lot of Italian Americans. They've all got votes I would have thought for that reason alone, Trump would be sending aeroplanes to Italy, trying to do what he could, but they're not. And the EU, as I said at the beginning of the show, have actually fined Italy in the last 10 days, 12 days, rather than come to help them. But let's look at the Italian example. Many people say that we're on the same road as the Italians, in which case the next few months are going to be very, very grim indeed for us. If our numbers, and our number of deaths, by the way, is increasing more quickly than the Italian was at that stage of the epidemic. But let's say we become Italy, Doctor. Can we cope with that? And if we can't cope with it, what's going to happen?
It's a very pertinent question. It's a very uncomfortable question to have to ask. As a doctor, as a medical professional, myself, my colleagues are very used to doing our best to reassure the public that we have their best interests at heart, that we're doing the best with the medical knowledge we have, that we have excellent technology and facilities to help them. But if we go the way of Italy, Italy announced a further 5,500 cases today, and they are overwhelmed by deaths, 650 deaths today. This is, of course, on top of normal service and normal mortality that we'd see in any population. They have an elderly population, as do we. They have a comorbid population, as do we. I think if there was one aspect, and we can talk about the economic things perhaps another time, but if there's one aspect of the medical care that I really think still needs changing and needs drastic changing, it's the ability to test on a much more widespread level. I have colleagues that I've worked with that I've found have become positive, but they themselves are only tested because they had been to high-risk geographical areas. Our criteria for testing are now woefully inadequate. It's generalized amongst the population. We know this. Many people, intensive care units, for example, in Norfolk Park, a hospital where I worked and trained and is as a very dear place in my heart, serving the population of northwest London, announced that they were overwhelmed by the number of cases they had in their intensive care unit. We're doing our best to divide our A&Es into respiratory and non-respiratory zones. But when you compare that to the efforts, the whole of society, economically, medically, socially, scientifically, was mobilized in China in order to get a lid on this. Now, China are worried that having got a lid on it, they still have a large percentage of the population, more than 99% of the population, who have not been exposed, and therefore the importance of a vaccine is clear if we don't want this to recur in larger portions and outbreaks to happen again. But they're in a very privileged position to once again just be worrying about a vaccine. I'm worried, as my colleagues are worried, about our capacity for patients who don't need intubation, our capacities who will need intensive care. And if we're going to do anything, as the World Health Organization have repeatedly emphasized to us over this period, we've got to roll out our testing on a much wider scale. And if that means requisitioning laboratories, this reverse transcriptase PCR reaction to actually identify the RNA tests from simple oropharyngeal swabs from patients, so just taking a swab from the nose and the mouth and sending it to a lab, it is possible to get a result. That should be scientifically possible in a country such as ours, which remains the 5th richest country on earth. And if we can give 330 billion to business, if we can support wages, and I think we should be supporting wages of people who are laid off at this time, it worries me still that with the closure of schools, there may be 3 or 4 million children who don't have their nutritional needs met adequately. And we, again, highlighting this point, we need to do some soul searching as a country to ask ourselves why the 5th richest nation on earth is in that situation.
Well, on that point, and finally, how can it be that the 5th or 6th richest country in the world hasn't even got enough face masks for its doctors and nurses, that they're reusing equipment that is not for reuse? How's that even possible?
You're right, there isn't enough personal protective equipment. Now, if you look at that document from China was very interesting because they talked about how to arrange the fever clinic and also the levels of personal protective equipment that were necessary for such an infective agent. And it is much more akin to You know, the CDC, the Center for Disease Control, working with these highly infectious agents, Ebola. I mean, it's these kind of levels of personal protection which go well beyond the normal clinical that we're used to that. So there's a huge increase in demand. That's no question. And that's not just this country, it's worldwide. Supply chains under capitalism, you know, everything that we make and everything that we consume in this country is no longer made in this country. So it does need repurposing. It does need us to think about the way our economy is run. But of course, the other thing is that our country runs in a way where, yes, we have a large state sector, but overwhelmingly what you see is that the national debt, you know, is publicized, is made public. So things which are loss-making enterprise are in public hands. Things which make wealth are in private hands. So there's a huge amount of wealth in this country. This country is awash with money in some regards, but its distribution is extremely uneven. So that despite the very wealth that our country has had for centuries as a part of its history, I'm afraid we have a huge resurgence of poverty, and it means that our state institutions don't have the ability of their own accord to immediately mobilize and rectify those systemic errors. And that's the legacy of the last certainly 35, 40 years.
Dr. Ranjeet Brar, thank you as always for a mesmerizing tour of the horizon of the coronavirus 19. Let's take a quick break. I'm well late for that.